I'm here.
Okay, great. Good afternoon, everyone. Well, I want to welcome everyone to what we're hoping to be a very interesting dialogue today. We have four really amazing speakers. And we have as well our excellent moderator, David Wertheimer. Would you like to say hello, David, so people know where you are on screen?
Hi, everybody. Here I am. Good afternoon.
I hope everybody's doing well. Our session is called Navigating Deinstitutionalization. And what I'm going to do is quickly introduce our speakers, and we will jump right in. We have three really interesting questions that we will be posing. David will be posing to our speakers, and I think given the number, we had over 200 people RSVP, and it looks like many of you all definitely showed up. So we're going to hold questions probably to the end. We're reserving about 15 minutes from the top of the hour to 15 after. And then, of course, if people have additional questions, they can email me, and I will be sure I put my email address in the chat when the speakers start their dialogue. And I have the questions, actually, I'll be putting in the chat as well, because they're very thought-provoking and questions that you might want to think about looking at in your own practice and your own work. So our panelists will discuss past and present mental health crises policies, addressing the challenges of a structure that often leaves its most vulnerable in the throes of hospitalizations, incarcerations, and homelessness. Drawing on evidence and experience, they will start a dialogue on the future of behavioral health policies and improving outcomes of those deeply impacted. Our first speaker, or at least first on the list, is Howard Goldman. He's professor of psychiatry at the University of Maryland School of Medicine. Howard is a mental health services and policy researcher with expertise in the organization and financing of services. He was also senior scientific editor of the Surgeon General's Report on Mental Health and the editor of Psychiatric Services, a journal of the American Psychiatric Association, from 2004 to 2016. He was elected to membership in the National Academy of Social Insurance in 1996 and the National Academy of Medicine in 2002. We have another Goldman in Dr. Matthew Goldman. He is the medical director for the King County, which is also where Seattle is located, King County Crisis Care Center's Levy Implementation Plan, which is a voter improve initiative to create 5 crisis centers, new residential treatment facilities, and workforce development programs across Seattle, King County. Dr. Goldman is a clinical assistant professor at the University of Washington, Department of Psychiatry and Behavioral Health Sciences. He serves as a board member of the American Association of Community Psychiatry, and he serves as well on the National Council for Mental Health Wellbeing's Medical Director Institute, where he co-chairs the Crisis Services Committee. He is also a physician scientist with numerous academic publications, book chapters, and dozens of presentations at national meetings. Very happy that he has the time to join us today. Will James is a Seattle-based journalist whose documentary podcasts have focused on mental illness and homelessness. He hosted the 2024 podcast called Lost Patients by KUOW and the Seattle Times. Sydney Brownstone, his partner, is an investigative reporter at the Seattle Times. She has published stories on sexual misconduct by public officials, jail deaths, mental health, and homelessness. She was also recognized as a Livingston finalist for her work on the podcast Outsiders and worked on the podcast Lost Patients with KUOW. Very pleased that both of these representatives from the media have joined us today. Our moderator, which I have to say is the best moderator I ever worked with, is David Wertheimer, who has worked in a variety of capacities in the nonprofit, government, educational, and philanthropic sectors for 4 decades. In 2019, he retired after 13 years at the Bill & Gates Foundation, where he most recently served as the foundation's Director of Community and Civic Engagement. With that, I would want to welcome everyone again. And David, would you like to jump right in? Okay, and we have just a quick reminder to put yourself on mute so we don't have a background noise. I think Ali Stoker, thank you. Okay, great. Thank you. David, would you like to jump right in?
Sure. Welcome, everyone. Great to see so many people here today for what I think is going to be a very rich conversation about a very complicated set of topics related to deinstitutionalization, mental health crises, and how to forge a path forward, learning from the mistakes of the past. And we have a really distinguished panel of speakers and who will have, I think, a very rich dialogue with each other about the 3 questions we're going to pose to them. And the first question is really a discussion of the past failures of deinstitutionalization efforts, highlighting mistakes that led to adverse outcomes for individuals who needed community-based care, including challenges with access to essential services and integration of those services into the communities in which people were living. So we're going to dive into that question first, and I'd just like to see which of our speakers would like to kick us off.
I'd be happy to go first because
Howard,
I have some other opening remarks. I don't know whether people are aware about the roundtable, but I wanted to thank Laura for having had the idea of developing this mental health policy roundtable more than 20 years ago. She had the idea when we were all in Washington that there were a great many advocates who were younger, just getting involved in the field, who didn't understand the context for a lot of the policies. And so her idea was that since Washington was full of senior people, that they could provide guidance to junior people if we met periodically. And it was amazing how many of the senior people were willing to dedicate time to meet with junior folks. We approached the MacArthur Foundation, where I had some funding, and agreed to pay for just refreshments and chances to meet. And my only gripe, Laura, is a great idea, but 20 plus years ago, I was an old timer. Makes me feel uncomfortable, but it's nice looking around and seeing people that I've worked with over the years. So I wanted to thank Laura for starting things, and thank David. David and I worked together on the Access Project more than 20 years ago. And I wanted to provide my congratulations to Will James and Sydney Brownstone for their really outstanding reporting. One of the things about deinstitutionalization, and it's been vexing me ever since I got into the field, is people do not present a nuanced picture of what deinstitutionalization really meant. And I think that Will and Sydney did an excellent job of not characterizing it the way the people who all know exactly what deinstitutionalization is all about when I'm at a social event and they tell me it's terrible, they closed the mental hospitals, and now all those people are wandering around. And what they really needed was more mental health services. And if I lead off here, it's vexing to realize that such a complicated process and set of policies could be reduced to this simple idea that is just mostly wrong. First of all, it has the idea that the mental hospitals were simple warehouses where people went in the front door and never left. And it misses the nuance of how the hospitals were organized. And missing that, means that the solutions that people offered were overly simplistic. And if I have one opening comment to make about the problem, it's that it was characterized as the problems associated with poor living conditions of people with severe and persistent mental illness in the period of community mental health and deinstitutionalization would be solved simply by improving the quality and access to behavioral health services. And it's my observation over the years that it's the social policies that underline all of issues related to chronic impairment and chronic limitations, the social determinants of health, and the policies that support them, or more often don't properly support people, are really the explanation for the failure of changing the functions in the mental health system so that people were not hospitalized for long periods of time, but then were able to live in the community. There was a lack of attention to these social determinants with respect to income supports being adequate, supported housing being available, supported employment for people who wanted to work, to earn money, as well as to perhaps be on disability, and a whole array of social supports. Poverty is the problem associated with severe and persistent mental illness that has led, in my view, to the poor living conditions that people like Sydney and Will described in their excellent reporting. So I'd like to use that as a way to sort of be the first offering and turn the mic over to our colleagues.
Yeah, to build on what Dr. Goldman was saying, I think that Sydney and I started out our reporting fully aware of the sort of mythology around deinstitutionalization that exists in the US. My mom worked at a state psychiatric hospital back home in New York. She was on the maintenance crew of a hospital called Kings Park Psychiatric. And it closed pretty late in the process. It closed in the 1990s or maybe the late 80s. And the mythology that I grew up with was, we would pass when I was a kid, someone who seemed to be homeless and in mental distress on the street. And the story my parents would tell was like, yeah, they closed the hospital and let everyone out. And that is, I think, a really common story that when you report on homelessness anywhere in the country, including in the Seattle region, people have really internalized that. And you see it popping up in our politics to this day. Donald Trump calls for the return of asylums as a solution to the problem of, mental health in the country today, and homelessness. So we're seeing that story, that narrative cut really, really deep. And as Dr. Goldman said, as Sydney and I discussed in the podcast, the story really is much more complicated. One way to view it is that deinstitutionalization was not the failure. The failure was to adequately support people into the next phase of our mental health evolution. A lot of people point first to the problems with community care, which was supposed to take the baton from the asylums. The fact that not enough clinics were funded, the ones that were funded often treated illnesses that were patients who were not seriously mentally ill. But also, the baton was dropped in many ways, again, as Dr. Goldman was saying, in the realm of the supports that were not medical in nature. So community care assumed that people leaving institutions would be able to find housing in their communities, which often proved not to be the case. Where people did find housing and could find community supports, they did better. But there seemed to be a lack of recognition during this period that the state psychiatric hospitals, in addition to providing care, medical care, psychiatry, also were sources of housing for the patients who lived there, often long-term housing if the patients were there for a long time. And when we closed those down or shrank them and switched to a new model, we did not have a model that housed the patients who were leaving. And we ran into lots and lots of problems when we made that transition. And I would throw it to Sydney or anyone else to add more to that.
Yeah, just to echo Will, I think one of the really big motivators in embarking on this project was the very narrative that Dr. Goldman identified. Will and I were both homelessness reporters, and that's something we heard very often. You know, the reason we have this homelessness crisis is because of deinstitutionalization decisions made decades ago. But as we kind of dove into the material, we found an interesting through line, yes, that had to do with those much broader seismic social changes that were happening at the same time, poverty and the collapse of affordable housing. But there also seemed to be this kind of ethical through line throughout our history where there's a kind of deal making that we do as a society where we are willing to accept horrible outcomes for poor people as long as they are sufficiently out of sight. And time again, we kind of saw that cost benefit analysis pop up again in policy decisions. And I think we tried to articulate that throughout the podcast as well. So in addition to identifying the policy decisions, I think we also have to look at the motivations for the policies. And it seems like a lot of them came down to austerity and ethical valuations on who deserves to be a member of society and who deserves to be out of sight.
Just to add to that real quick, that was a shocking part of reporting this podcast and looking back into the history of deinstitutionalization in Washington state, where Sydney and I are based. You know, the story is often that deinstitutionalization, the closing of the state psychiatric hospitals, was for the civil rights of patients who were subject at times to like abuse and really terrible treatments and warehousing at these places. And that's partially true. But when we look back at the records here in Washington state and the decisions to close Northern State Hospital, which is a big psychiatric hospital outside Seattle, those discussions were overwhelmingly about cost. It was about the state trying to save money and very little discussion about the welfare of the patients. So when we look at why deinstitutionalization and the transition to community care went wrong, I think, like Sydney said, the motivating factors got sort of scrambled or confused at a certain point.
Thanks, Will and Sydney and Howard. Matthew, anything you'd like to add before we move on to the next question?
I think that was very well covered. No, happy to move on, and I'll probably have more to say about the next couple.
Okay, very good. So our second question, because we want to leave time for discussion at the end here, and we're already almost halfway through. What steps can be taken to prevent mental health crises before they occur and the need for hospitalization at all? What can we be doing differently? Who'd like to dive in?
Seems like your bailiwick, Matt.
Yeah, this could be where I hop in here. So happy to, and this is really two questions in one. The prevention of mental health crises before they occur and reducing the need for hospitalization or higher level of care. A couple thoughts on this because I think they are related, at least insofar as good postvention is prevention. So, after somebody is already experiencing some sort of more intense crisis type experience, to then give them care in a sustainable way that's then going to prevent them from having a recurrence of that experience is a way to prevent. But prevention more broadly, there's a lot to say there. I think, part of what the story of deinstitutionalization is about the under-resourcing or lack of sustainability of community-based services. And those community-based services are the ones that are supposed to be able to help meet people where they're at and prevent onset of a crisis when their needs aren't, fully covered in the community. So I think that relates that way. But where I want to focus a little more is on the reducing the need for hospitalization. I'm a crisis services medical director, so I come at this with a clinical lens, but also a systems lens of how do we build systems that are going to better serve people and their needs in less restrictive settings, meaning settings where there's lower likelihood of needing to take somebody's rights away, settings where it's more likely that people can stay in control of their care. That is really the kind of setting that we're wanting to prioritize and stand up to the extent possible. And so, speaking from our experience here in King County, Seattle area, we have recently invested significantly in developing crisis stabilization facilities that are really designed to do this. And I want to share a couple of things about the structure of these programs that lend themselves to being able to deliver care in this more person-centered way. So we're creating 5 of these centers across the county. This is all supported by a property tax levy with a significant investment, about $1.25 billion of property taxes will support this over the next 9 years. So we're very fortunate to be in an environment where we can do something like this. But so much about the model that we're designing in each of these 5 crisis care centers is, first of all, that they have a strong emphasis on being trauma-informed, prioritizing peer specialists, people with lived experience as a core part of the staffing to engage people as they're coming into the center and continuing to work with them and meet their needs and understand what's going on. There's a strong focus on integrating care. So this is not just a mental health setting. This is also a setting where people with substance use, with co-occurring mental health and substance use needs can get services. People who also have social service needs or need referrals to housing or homelessness resources. People who might have a developmental disability. Really having a broader scope than what's typically been prioritized or even possible with current resources has been a major focus. And what that allows for is really welcoming anybody in. It's this no wrong door idea of, anybody's welcome here. We've got what you need within the sort of realm of mental health, substance use, behavioral health writ large, but wanting to be able to address these other needs that so often co-occur. And then the last piece that's really important is that these are also multi-component settings. It's not just like a single door and you get what you get and then that's it. There is an urgent care component. There's a higher sort of acuity 23-hour observation component. There's a longer term 14-day component. And then there's a strong emphasis on post-crisis follow-up. And what all of that allows for is it makes it so that the program has complexity, but the person's experience is I can just go there and get what I need. And the program will be able to figure out, well, it sounds like urgent care is going to meet your needs, or maybe we need this higher acuity setting, or maybe, maybe hospitalization is needed for you, but there become many other gradients and options of care that somebody can access in this one setting that don't require hospitalization. And right now, we don't have that. We only have emergency rooms as an entry point where really it's a question of, are you safe enough to leave and go back into the community and not get much follow-up, or do you need to come inpatient? This new model of crisis stabilization that has all these different components and allows for all that different triage, it allows for much more of a person-centered, patient-centered design. So I'm hopeful that will then, by meeting people's needs better in these less restrictive settings, we'll be able to help prevent hospitalizations that might otherwise not be needed, and even help prevent downstream crises by connecting people to that longer term post-crisis follow-up care. But there's a lot still to figure out about how we implement this kind of program at scale across the nation to be able to meet the extent of need that we really see.
Thanks, Matthew. Will, Sydney, Howard, any thoughts on this second question?
Well,
Oh, I was just going to say very
Good.
briefly, what's really interesting about what the other doctor, what Matt is working
I was
on.
gonna say, call me Matt.
Yeah.
Howard, he's the
Matt
Dr.
and
Howard
Howard.
honorific. He
Yeah.
Call him
outranks me.
Sid.
Yeah. What's really interesting to me about what Matt is working on is that when King County leaders announced this initiative a couple of years ago, they framed it explicitly as the antidote to, or an attempt to reverse the mistakes we made as a society during deinstitutionalization. They came out and said, you know, we really messed up 40 some odd years ago when we tried to roll out community care. And this is our first step at reversing those mistakes. The same thing is going on in California right now. Governor Gavin Newsom is, for the past few years, has been embarking on a whole suite of mental health reforms, some of which expand involuntary commitment, some of which expand beds and inpatient capacity, but he's framed it the same way. You know, he called it California's original sin, the botched transition from institutions to community care. And half a century later, he's trying to undo it in his own way. So I don't know, I find the historical framing of these efforts really interesting.
Well, that really sets up the remarks that I wanted to make. But before we get into the history and how not failure to understand the history of and the complexity of hospitals as organizations providing housing and treatment, there are services that are effective for people with well-established severe and persistent mental illness. Assertive community treatment is the obvious example. And while it was introduced in the 1970s and has been implemented across the country, there still is a much greater need for those services. And even today, we're having difficulty paying for them, not just the total quantity of resources that are needed, but to finance episodes of care, a month of care. We still are inadequately funding the services that we know work for those individuals for whom a hospitalization could be prevented by improved community-based services. But I wanted to go back to this history. I don't know exactly where to start. The conventional wisdom about those mental hospitals was that, as I said, people were admitted and never discharged. They died in the hospital. And when they closed the hospital beds, for every bed, there was one person who needed to be housed. Well, that may have been true of the so-called back wards of the state mental hospital, where people did go and live for the rest of their lives. But that doesn't characterize the hospital in its entirety. I mean, it is true that starting in the late 1800s and up until about 1920, each state passed a State Care Act that required the state to provide treatment for people with mental illness. But at that time, treatment meant hospitalization. And it was a way of centralizing financial responsibility at the state level. What it led to was the redefinition of dementia and chronic alcoholism as mental health problems. And people were sent to live in state mental hospitals, which grew and grew in size, so that by 1955, there were over 500,000 beds in state mental hospitals. And while a large number of them were really like nursing homes, the front wards of state hospitals were admitting patients. I wonder if anybody would like to hazard a guess when the length of stay for patients newly admitted to the hospital began to decline. In fact, there was a study done at NIMH back in the 1960s that studied the dynamics of state hospital in Pennsylvania, the Warren State Hospital, and showed that for patients who were newly admitted to the hospital, the length of stay started to decline in around 1910. Well, why is that really important for understanding what's going on in the state mental hospital? If the length of stay for newly admitted patients is constantly being reduced, the number of beds that are required to be staffed to treat patients in the hospital is dramatically reduced. If length of stay was 6 months, you needed 1 bed for 2 patients. But as lengths of stay reduced from 6 months to 6 weeks, you now could turn over a bed much more quickly, and a much smaller number of beds would be needed to care for the patient staying for 6 weeks. And when lengths of stay started to decline to 6 days, they could reduce the number of beds further. And if you take the beds out of service, that's where the savings accrued. But the conventional wisdom is that with deinstitutionalization, hospitalization declined, when in fact hospitalization remained at the same level from 1955 to 1975. It's shifted its locus of care. And just as the State Care Acts provided financing that turned state mental hospitals into nursing homes, Medicaid and Medicare's passage allowed the back wards of the state hospital to be converted to nursing homes paid for by Medicaid, and Medicaid resources could be used in general hospitals to pay for inpatient units in general hospitals. So while the front wards of state mental hospitals closed, the acute care units in general hospitals expanded and hospitalization continued. And that's why the appropriate consideration is, how do you prevent the hospitalization, and how do you support people who need the hospital to be able to get treatment in as short a period of time as feasible. But housing policy and income support policies, vocational support policies, were all essential to keep people living at a good quality of life in the community. And as I said before in my opening remarks, the thing that has pained me and required me to focus my policy work way beyond the walls of inpatient psychiatric units and community mental health services to concerns about disability policy, income support policies of other kinds, housing supports, housing subsidies. And without those, people can't live a decent life after a short hospital stay, or for people who can avoid hospitalization entirely but need services. They still need to have their basic needs met, whether they provide them themselves through supported employment or they get a hand up. And there simply is not a guaranteed right to housing or to housing subsidies for people who can't afford that care.
Thanks, Howard. In the interest of time, I'm going to move us on to the third question. And Laura, we have, I know, a lot of interesting comments and questions in the chat. So if you want to begin sorting which questions you'd like to ask our panelists from the questions that are in the chat, I'm going to move us on to our third question, which is, how can we learn from past mistakes? And clearly we're hearing today how many there have been, to forge a new path forward, ensuring individuals avoid the cycle between hospital, jail, shelter, and the streets. And what lessons should shape the next 50 years of behavioral health policy? I'd like to dive in.
Just a quick note before someone dives in. I just want to remind people that we'll go ahead and put the link in again, that Lost Patients had, I think, 6 or 7 episodes, and episode number 4 really gets to this number 3 question that we have in front of us. And I want to say, if you, thank you, Vicki, that if you listen to any one of them first, I would say listen to number 4 first. it just really touched me as someone who has only merely been a pupil in the classrooms where Howard Goldman talks. But what hit me, which it never really would have if I didn't listen to that episode or listen to Howard speak in the many years that I got the opportunity to do that, that so much was done more than 50 years ago, almost the exact same work with different names perhaps, have been repeated almost every 50 years as what we think is a new cycle, but of change and reform, but really is just a simple inch step forward. And it just moved me when I listened to Sydney Brownstone's narration, where I almost wept, and her voice was almost similar to that, about the level of work that we had put into the field, again, 50 years earlier, and how almost it's beyond the term frustrating of where we are today, 50 years later, which is not that far. And it just made me, kind of weep for the workers that have been working and toiling and trying to impact recovery. It made me cry for the patients that could have been well a lot sooner and maybe on their feet, affording housing, for example. And it just nudges me now to the future where we're at now with states impaneling bodies to kind of refine and reallocate services that are so slim and far between. So I just want to just bring that up in the context of number 3, and hopefully you can listen to episode 4 as well. I'd love to hear your thoughts about that.
Thanks, Laura. I mean, well, thank you for your kind words about episode 4. I can talk a little bit about the moment Laura's speaking about. So I am not obviously a subject matter expert in the way that Howard or Matt or Laura are. I'm a journalist, and I've covered homelessness and to some degree mental health over the last several years. So I can talk about what I've learned from that perspective, which is, my own limited lens viewpoint into this. The moment that Laura is referring to, I am going through the Seattle Times archives, and I find an article from 1981 talking about people bouncing from the Morrison in downtown to Seattle to the King County Jail to Western and back again onto the streets. And I eventually flipped out because I said, this is what I've been covering. This is what I've been covering in the years 2019, 2020, 2021, to the present. How are things still the same? And that was a big motivation to look further back in history to see if there were patterns that I could find. And the impetus for the podcast started at a moment where Will and I were standing in the cemetery of Northern State Hospital. And Northern State Hospital used to be one of 3 state hospitals in Washington. And it was the one state hospital that was closed during deinstitutionalization. And what was notable about the cemetery is that most of the markers identifying patients there had sunk into the mud. So no one's identity was visible, and the markers that did exist were just initials and a number. And that really struck me, that there's this institution that was closed and it has been memory holed, on the grounds of Northern State. There's not a museum there. There's not walls or docents explaining what this means and how we can do things differently going forward. It's like we abandoned that institution and then never wanted to talk about it again. So that's what motivated me to start looking at the story of Northern State. And the story that I found was different, as Dr. Goldman and Will have alluded to, than the story that we've often heard about deinstitutionalization. I mean, when we looked at Northern State, we found that in its earlier years, it really had been an overcrowded institution of old, with lobotomies and insulin comas and locked wards and women who were sent there by their husbands. But the interesting and kind of counterintuitive narrative we found was that in the 60s, it really changed. And at the moment when its leaders were advocating for integration with the community and short periods of hospitalization for patients with the most acute needs and lengthen or decreasing the length of stay. At that moment, when it seemed like the leaders within the institutions were on the cusp of developing something that is closer to the standards of care we have today, the institution was shuttered, and we kind of got into this fractured system. And I think that's important to recognize, because I think it helps us break out of the cycle if we can think about policies not as distinct policies, like this policy was good, this policy was bad. I mean, obviously you should evaluate policies, but look at the decisions driving the policies. And I do think that whenever fiscal concerns are at the top of your concern list, it does result in a degree of human suffering. The other thing that gives me hope for breaking out of this cycle, and again, this is just my perspective as a journalist, is we interviewed, Will and I, several people with who have experienced psychosis before. And one of those interviews really touched me. It was this woman named Carolyn Panzoa. And we asked her what would have helped her prevent some of her hospitalizations or her most acute periods and longest periods of psychosis. And she said, just someone to spend time with me while I'm symptomatic, someone to go with me to the grocery store. And that struck me because I think it's something that everyone, even non-clinicians or researchers or policy folks, can embrace, to try and be present with people we know are experiencing symptoms of serious mental illness, or if we're able, and provide that kind of support, obviously in more concrete policy terms. And I think that also means expanding our definition of what normal behavior looks like. So rather than looking at people who are experiencing the symptoms of mental illness and think, okay, they have to be shut away because they're symptomatic, how do we, while embracing those people as full members of our society, help them? And now I'll stop talking. Those are just my 2 cents.
Thanks. So we have really only about 13 minutes left. So Laura, do you want to pick any of the questions from the chat to pose to our panelists? If you think there's some prioritizable questions in there.
I did see a couple of, many are statements, but Mark Salzer raised an interesting point. Mark, do you want to repeat your point on the line since you're here, or would it be better? Would you rather I read it? I saw it, Mark. There you go.
Sure. So I'm Mark Salzer. I'm a professor at Temple University and have worked in inpatient settings, other types of settings. And as one of the solutions or things that we need to really get serious about, it is paying attention to social determinants of health, poverty, and exclusion of people with serious mental illnesses as major stressors. These are things that I've seen plenty of people experience crisis and hospitalizations as a result of problems related to this. And other disability populations have taken this orientation. They focus on inclusion. They focus on opportunities to work and go to school and dating and parenting and friendships and voting and volunteering as important for life and important to health as well. And we don't pay enough attention. ACT actually used to pay attention to this kind of stuff originally in the 60s and 70s. It doesn't very much anymore. That's why I think it was partly effective. Anyway, those are my comments. Thanks, Laura.
Sure. Okay, Matt, I wondered if you had anything that you wanted to add at all around question 3, if anything's come up as you're looking at it.
You could read my mind, and this actually, I think, follows up to a point that Mark just said, which it came up in many ways. Like, so how do we set that future vision? And just reading the comments in the thread, and also knowing a lot of the folks who are here in this room, in our process for designing the programs that we're implementing here in King County, we were fortunate to really have a mandate to have an inclusive process where we had to engage a lot of different folks in the community in order to help inform us about like how do we stand up what we're trying to stand up? We've got all this money, we've got all this sort of necessity. It's a crisis, it's a mental health crisis, an opioid overdose crisis, a youth mental health crisis. There's all of these major pressures that need to be addressed with such urgency. There are then, of course, major inequities in how services are delivered. There are major, gaps in how certain populations are actually receiving care that's appropriately culturally and linguistically tailored to people's needs. There were all of these different factors. And so then, where do we go? How do we organize this? And I will say that having people with lived experience in mental health and substance use, people who had actually navigated these services, participate in our process, helped shape so much of what we did. And I'll give a very concrete example. In Washington State, we have this process where we use designated crisis responders as the people who have the authority to put people on involuntary holds. And there was a long discussion in our planning process about what is the role for designated crisis responders, DCRs, where should they be relative to the programs? And the original program model had actually committed that DCRs were going to be stationed at these centers that were standing up. But we heard loud and clear, especially from some of the folks at Pure Washington and other advocates, that if there were DCRs at these settings, people weren't going to come. And we would be spending $1 billion on a program that wasn't actually going to be what people wanted. And so we made a policy decision to not have DCR stationed at crisis care centers. We're legislatively required, the way that any community-based setting is, to allow designated crisis responders to enter into the setting to do an evaluation if needed, but they wouldn't be embedded in the program in a way that would be extremely off-putting to the very people that we're trying to make this program actually work for. And so, governments have blind spots. We are but bureaucrats trying to do our best in public service, but we know that we're not always going to get it right. And I feel passionate about, as much as possible, including folks who actually know about what we're trying to do here based on their experience actually trying to utilize these services, participating in our planning processes. That, I think, is happening more and more and can really, I hope, shape how this is going to go over the next 50 years. The more we can do that, the better.
Thanks.
Point, Matt, thank you.
Laura has just let me know we're going to go till 2:15 today, or
yes,
on the East Coast. So we have time for some questions and some discussion. So Laura, anything that you want to pull out of the chat to ask our
Yes, Allie Middleton brought up a good issue, and then also there's another question after that I'll bring up from Karis Myrick. Okay. Allie talked about kind of a new model for leaders, system sensing, and with us looking at it, having a very much a historical perspective, how might system sensing and presencing occur to bring leadership practices forward and more collaborative competencies, similar to what Matt was talking about around inclusion of peer voice. Allie, do you want to add to that point at all? And are you still with us? Yeah.
Only very briefly, Laura, thank you so much. And thank you to everyone who's showing up. As a former enactor here in Columbia and Greene counties and Albany counties in the way back days when person-centered recovery systems of care were at the early stages of innovation, the only way we got anybody involved was to get them in a room together. It's already been mentioned about open dialogue and these new communication strategies to shift the stigma to the lived experience in a creative context. So what does that mean for experts, policymakers? I'd like to point to Shelley Wiseman down in Georgetown, who's doing something very similar with the Substance Abuse New Policy Initiative, bringing people out of the field who've made innovative strategies and have been successful, and then helped by those who've been in the system to actually create new opportunities for more voices who have had the time in. And what does that really create, Laura? You know, you and I have been in conversation for decades about this. It creates an open system, and that we sense from a compassionate perspective the need for all voices. It's a longer journey than taking the pharmacological and the capital work of an institutional care setting. It means bringing people out of the woods. So I'm all in favor of a rather messy transition process, and I do hope that Kings County is enabling more voices in, and perhaps innovating with some of these new awareness-based change practices, such as Theory U and the work of the Presencing Institute at MIT. If that's new for people, there's some great resources I'll plug into the chat. Thank you, Laura.
Thank you very much. I just want to point out that just one kind of parenthetical point, that because I've gotten to know Matt and his philosophy and run into his name in terms of a citation in the least likeliest of places, because I didn't realize how well-spoken he is and how he's written basically encyclopedias on the issues that he's working on, that I trust him, and I haven't even known him a year yet. And you could laugh at this, but I've kind of let you be, Matt. I'm not like calling you up and saying, you didn't include at that meeting. Where's the inclusion? And I just, I know that he's doing that. And I know that because I had some interactions with him right before he started in his new role. But I also know that because I've done some homework. But I know that too because I've watched him work. And I just feel really strongly about these crisis care centers, that they're voluntary, that they're the urgent care centers that we have for broken legs and twisted ankles, but we don't have for psychiatric emergencies. And I just feel like this is being led with in the right way. That has a lot to do with the way these systems have even failed or succeeded, with relationships that work, with trust that works, with political will that works, leadership in our county executive that I had mixed feelings about until he brought on this levy idea and really worked closely with legislators and other people to get it implemented. So much of that goes into play too that we don't often get to talk about, but please look at those relationships, and I put in a plug for that because it's crucial, I think, to the success of what we're trying to do here.
Very good.
Kiris Myrick had a point to make around people of color and racism, and I cannot find it, Kiris, so would you please go ahead and ask your question in verbally instead of chat?
Sure, and thanks so much. And I'm going to double down on Matt as well, having worked with him over the years from SAMHSA to California, et cetera, and could not speak more highly of somebody in the psychiatric profession who gets it and will work alongside people with lived experience and family members, et cetera, to improve our systems. But anyway, my question, and it actually comes from California, and you talked about California and what's happening here. And in the midst of some of the shifts here to move towards more use of coercion to get people into treatment, I wanted to dig into the data to understand how do we understand who is under these coercive orders already. And actually, there was little data available, like there was no requirement to collect that data, which I find really fascinating, that you can take somebody's rights away, but not even have data on who they are, where they are, how they're doing. But one place that did do good collection was actually San Francisco, who was in San Francisco? It would be Matt Goldman. But anyway, from that data and other data, we found incredible disparities, particularly for the Black community of folks who were under orders. We also know from California data writ large, the disparities for African Americans who are unhoused. We also know historically and currently about the disparities of diagnoses, overdiagnoses still of African American men with schizophrenia. So we have this perfect storm. And within this perfect storm, we actually perpetuate disparities when systems want to continue to double down on using coercion as a mechanism of getting people into treatment and or supporting them. But I haven't heard any of the speakers yet, and Matt, you did say it as well, but talk about what needs to be different for communities of color, unserved, underserved, or inappropriately served communities in order to get them the support they need. Because, just yesterday, another Black woman was shot in the face while she was in a mental health emergency by the police, and the police were with her for 30 minutes and could have, in that time, used 988 because that state does have 988 where this happened. So I just want to lay that out there, that this discussion to me can't happen without some kind of nod and appreciation and dedicated work to communities that experience disparities. Thanks.
Thanks, Kara. It's really important comment to add to our discussion, and I would invite any of our speakers to respond and elaborate further on the disparities that exist based on race, ethnicity, sexual orientation, gender, etc.
Yeah, I think that's an incredible point. And I think Will and I have talked about this before, but we did not specifically look at that in the podcast, and we wish we could have. I published a story not too long ago looking at something happening here in Washington State where there is this kind of hospitalization to criminalization pipeline that once people are hospitalized in acute psychosis or they're being taken in on involuntary commitment and they lash out at a healthcare provider. Sometimes they are taken out of treatment and put in jail and then charged with an automatic felony. Some of the assaults really are very violent and felonious level assaults, but a lot of them are just spitting on a healthcare worker. And one thing we found is that the vast majority of the people charged are people who are Black. And I think, there's this kind of, there's this other track in where the criminal justice system or the criminal legal system has become the front door to a lot of our mental health care. And figuring out how to not make this type of care only accessible once people are in jail is key to reducing some of those disparities, because they are wild and they are still happening. And say that.
Thank you, Sydney. And I will echo your thoughts. One of my good friends, Judge Wesley St. Clair, here in King County, refuses to talk about the criminal justice system. He calls it the criminal processing system. And he's a judge. So let that sink in.
Yeah. I wanted to call on Clifford, has his hands up first, and then Yulia right after Clifford.
Very
Clifford,
good.
go ahead.
Clifford.
David, hi. Laura, it's always great to be in your presence. Thank you very much.
It's been a long time. I'm glad you're with us.
Yeah. Well, right now, I am the chairman of the board for the Southwest Washington Behavioral Health Advisory Board.
Uh-huh.
And I want to speak to the Peer Bridger program that's been intact since 2016. I worked very hard with the legislature, the Senate Ways and Means Committee, Chair Christine Rawls, and the late Andy Hill in getting funding for the Peer Bridger program, which is a huge success at Harborview Hospital and here in Clark County. Clark County is the biggest recovery center in Washington State. There's some reason I had to move here, and that was it.
Oh, right on.
Yeah, so, I'm doing good things.
Good.
Great to you. I want to super emphasize the Peer Bridger program. It's all over the nation.
That's right.
It's working. Okay, and it needs to expand. Peer support services need to expand. That's the future.
Thank you, Clifford.
And
I want to see you. We'll catch up soon.
yeah, we will. Thank
I'll
you.
send you an email, okay?
I love that.
Julia,
Okay.
You're up.
Thank you.
Julia, you're up.
Yeah, thank you very much for this wonderful discussion. That's very inspiring, gives real hope. And I wanted to make a couple of points. One was already made, that there are services that are non-corrosive, that are evidence-based, that work, and all that is lacking is political will. And definitely peer support is one of them. Open dialogue for psychosis is another method, and there are other approaches that actually work for what is conventionally called severe mental illness and psychosis. And I know that as, you know, family member experience. So my daughter was really damaged by psychiatric treatment, and then recovered completely with open dialogue. And I wanted to also respond to the point about people sent to jail for assault on providers in hospitals. I can imagine that some of those assaults are genuine, but what I myself, I witnessed in my daughter's hospital and heard from a lot of other parents, a lot of ex-patients. In a lot of cases, people are really provoked to make an assault. You know, I did not have any psychosis, any mental illness when I was there. I had to exercise all my willpower sometimes, actually not to lose it. The way I was treated as a parent, the way, you know, employees talk to me, I was never insulted in this way. I never encountered this kind of rude behavior in my life. And if somebody is already in crisis and they are treated this way, then assault is not actually exactly their fault. I just wanted to add this little nuance. Thank you again very much.
Thank you, Julia, for your candor and your comments.
I could speak to the idea of political will for a moment. That is, when we had our third question about the path forward and what we learned from deinstitutionalization, the idea of political will came to mind for me. What was deinstitutionalization? Like, as we've discussed, it was a bunch of different things. It was, you could say it was like the split of housing from psychiatric care in one way. It was a bunch of things. But one of the things that it was a stepping back of state governments from psychiatric care for the most disabled patients with serious mental illness. So before deinstitutionalization, state governments around the country were very heavily invested in providing care for the most seriously mentally ill people at state psychiatric hospitals. After deinstitutionalization, care was provided directly, no longer by the state in many cases, but by a mishmash of nonprofits, of local agencies, of for-profit hospitals. It just, the system fractured, and the state sort of took a step back from this responsibility. And I think today we're seeing gradual incremental efforts for the state to sort of take back some of that responsibility. But I think, you know, that is one of the lessons of deinstitutionalization, is that we need to, as a society, take responsibility for these very disabled patients and not, you know, lack the political will to really do something about it, to not exist in this status quo where the responsibility is sort of diffuse and this one nonprofit is responsible for this one little piece of someone's care. And then once they walk outside the door, it's not their problem anymore. And then they go to the emergency room and it's the emergency room's responsibility for like a few hours. And then once they leave the emergency room, it's not their problem anymore. Like that diffusion of responsibility, I think, is one of the legacies of deinstitutionalization. And it's something that is going to take a long time to reverse, but it's something that probably will have to be fixed if we're going to make progress here, in my opinion.
Thanks, Will. Donald, I see your hand up.
Hi. I have a thought because my comment has not been really addressed or thought about through the conference. And that is, I'm a psychoanalyst as well as a psychiatrist. I'm also in episode 6. So I come with those kinds of threads. But my concern is that when Laura brought up the issue of repetition, that we have 50-year cycles. Well, some people have 5-day cycles. If you're a patient in a hospital, you're rehospitalized within a week. We have $250 million that the state has given, and yet we repeat the same mistake. So as an analyst, I'm interested in motives, and I'm interested particularly in unconscious motives. And so one thought I had is that hospitals do not exist for the treatment of severe mental illness or distress. Hospitals exist for the protection of the vulnerable by the vulnerable.
Did we get it replaced?
Yeah, so I have this one now. I heard you got.
Oh, yeah, thank you.
Yeah, so hospitals don't exist. If you look at it de facto, hospitals exist to protect vulnerability, both the caregiver's vulnerability as well as what we call the patient's vulnerability. That's why you can have involuntary treatment. That's why you can have excessive use of medication. That's why you can address a cure when behavior is mitigated, but it's no cure for the patient or the caregivers experiencing this kind of distress. So I would like to have our organizations analyzed, because unless these motives are analyzed and brought to the fore, you can throw $1 billion into it and we'll repeat the same cycle. Thank you.
Thanks, Donald. Okay, we've got only about 3 minutes left. So any closing thoughts from any of our speakers before we wrap up?
I just think we have to continue our advocacy in the broader social welfare realm as well as in the specific specialized behavioral health services. I have a new grant with Nev Jones, person with lived experience in early psychosis treatment. She and I are looking at trajectories of people about their decision to go back to school, to go to work, or to go on disability after a first episode of psychosis. And there's a policy part of our research, in addition to doing interviews and some quantitative study of a large data set. And we've already come to the appreciation that the mental health field is no longer really well engaged in issues related to SSI, for example. The broader disability community is working hard to improve SSI, improve compensation. The same is true for housing policy. We've demonstrated that people with severe and persistent mental illness with supports can live in ordinary housing, but they can't afford it. We've shown that people who get housing subsidies can live in normalized housing with supports. But we haven't made housing a commitment as a right. We don't even have health insurance as a right, although we've done a much better job of improving access. I would just say that in addition to our recognizing unconscious motivations, there is a lack of political will that ought to bend to the will of advocacy. All right.
Well, until we no longer have those incidents that Karis mentioned, the woman that was killed by the police, and that's been widely publicized. And until we stop that, there's really no hope in going forward, in my view, that we've got to really stop killing each other so that we can actually live meaningful lives. And I'm sorry, but get to the point of some of what you're saying, Howard, because we're somehow saying it's okay to kill people if we keep letting it happen like this, because it'll be another 12 months before there's a trial or whatever. I'm just saying that it doesn't equate with what's actually going on. So I respect your point of view, but until this other current day picture changes, we've got to, I guess, similar to what Will was saying, we have a long way to go.
Yeah. We have work to do. And just let me say that it's nice seeing some faces, people I've known and worked with over the years in the audience. I see you.
Very good.
You know who
Hi,
you are.
D. Roth. D. Roth, hello.
I saw Dee wagging her fingers at me.
Yeah. I saw Tom Traben too at one
Yeah,
point. Yeah, Tom Traben. Well, we're going to do this again because the issue is still here. I'm going to convince Will that he needs to do another half dozen podcasts and make it an even dozen. And we'll come back and continue the dialogue.
You really have to listen to the interview with the guy, former governor of Washington State. That was pretty brilliant.
Oh, yes, yeah, exactly. There's a public policy. He's a wing of the University of Washington named after him. Evans, is that right? Yeah.
Yeah, when we did this in Washington, it was nice. We were all together, but we never had this many people.
I know.
I was really pretty impressed.
We broke a record in terms of attendance as well as RSVPs. 212 people RSVP'd. At least half did come, almost half. So that's my rule of thumb. I want to thank Matt Goldman for being a part of this session. He's new at King County, and we're very happy that he is here. Howard Goldman, thank you so much for spending the time here this afternoon. And also, my hat goes off to Will and Sydney. We'll hear you on the airwaves. And finally, Dave Wertheimer, looking forward to the next roundtable. We'll do it again. Have a good summer, everybody, and thank you.
Thanks, Laura. Thanks, everybody. It's good to see you.
Thanks so much, everyone.
Bye, everybody.
Bye-bye.